going to begin our event now. Good afternoon, good evening to all who are joining us from the various locations in the world. And welcome to WCAPS Race Across the Pond Initiative panel discussion, COVID-19 Equality and Equity and Access to Vaccines Globally. This event is part of the Race Across the Pond's Women of Color in Healthcare series. My name is Laëtitia K. I am a global health consultant specializing in infectious disease surveillance and outbreak preparedness. And I am also a member of the Race Across the Pond team specifically for their initiative in healthcare. So some quick housekeeping as people start to come in, and we will be posting this information inside the chat. Please feel free to ask questions in the chat. We absolutely love to hear from you, and we love to see you all engaging in the discussion, but we are going to be asking that you kindly be respectful to one another. And please, if you are not already done so, mute yourself upon entry. We do love to see your smiling faces, but so everybody can hear the speakers and hear questions as they come up, we would really prefer if you would mute yourself. Please also do note that we will be including any important links that are referenced in the conversation in the chat as well. And if you haven't yet, please do check out our WCAPS website and check the Race Across the Pond initiative through the website. Throughout this event, if you are willing and able and wanting, please feel free to share anything that's mentioned here through LinkedIn, Twitter, and Facebook using the hashtag WCAPS Wraps Initiative, which we will be posting in the chat for your convenience. And through Twitter, feel free to tag us at wcaps.net. If there's any more questions, mentioning that you can always find more on wcaps.org. So a little bit of housekeeping. This event will be recorded and will be available later on YouTube. This conversation will last approximately 1 hour and 30 minutes and will be divided into 2 parts. The first part will be dedicated into our panel discussion, in which our experts and consultants will be discussing vaccines in circulation, the process by which the vaccines get from manufacturer to the country supply chains, and actually the process of distribution of these vaccines. Specifically, once access is available to the vaccine in a particular country, how is that process going of actually getting vaccine from country facility to the general populace that needs it? The second half will be an open Q&A where you will be allowed to ask questions that you have about this talk, and we strongly encourage you to please ask questions. If you wish to populate them in the chat as you wait, you can, but I'll say too that we are always going to be opening the floor for anybody who would like to ask any particular questions themselves. I do also want to note that during this conversation, we will be utilizing the term Global South. And within the context of this particular conversation, and for the purposes of this conversation, Global South will be used to encapsulate countries that have been defined as low and middle income countries, countries that have been defined as those with emerging economies, countries that have also been defined as peripheral countries, and countries that are politically and culturally marginalized. The term Global South does not mean geographic location, as there are many countries within Europe and Asia that do fit under this use of the definition Global South. And before I introduce the panelists, I would like to first thank all of my colleagues who have worked with me on this initiative. My colleague Yasmin Abdouli, my colleague Sherihan Ben Siman, and then my other colleague Sarah Boulouche. And we're going to open the floor for Sarah to say a few words on this WRAP initiative.
Hi, everyone. Thank you so much, Laëtitia. And I'm very happy about this event. I'm very excited about this discussion. So I'm the chair of the Race Across the Pond initiative. It's a project, a global project that has been created about 6 months ago. And the objective is to analyze and explore the impact of race and racism, we like to talk about constructed race instead of race, actually. The constructed race and racism on the lives and human security of Black, Indigenous, and other people of color globally, and also the threat that it poses on international security and peace. So the idea is that we look at these issues from different perspectives and with different methodologies. We bring people from different backgrounds and specialities, and mostly, because that's the goal of the WCAPS, is to bring the voices, to elevate the voices of women of color from different countries globally. And it can be through with diplomats, social science experts, peace builders, security and defense experts, economists, activists, or like today, public health experts. So thank you so much, Laëtitia. I'm very excited about this event. Please visit our website, Women of Color, Advancing Peace, Security, and conflict transformation is actually an organization. I should have started with that. It's an organization that has been created 3 years ago by Ambassador Bonnie Jenkins, which we are very happy to have today with us. And on that, I'm actually going to leave her to give us some few words before I hand back to Laëtitia to start this event. Bonnie?
Hi, everyone. Thanks, Laëtitia. Thanks, Sarah. It's so great to see everyone here. Like all of you, I'm looking forward to a really interesting discussion. I want to thank all of the individuals who planned this event, Race Across the Pond, particularly our leadership, Sarah, for what she's doing, and all of the panelists who joined in. I'm happy to see that this is being recorded so that we can actually share it with others who cannot make it today. So I just want to keep it brief and just say thanks to everyone for being here and for our leadership, the Race Across the Pond, and our working groups who are working with Sarah and the work she's doing. So back over to you, Sarah.
Thank you so much, Bonnie. Adding on that, actually, so there is the Race Across the Pond initiative, which we are renaming RAP initiative to make it shorter and easier. But please note also that there is a lot of other working groups, chapters also in many countries, in UK, in France, in Ghana, in Canada. There are new ones coming up also in Nigeria, in Colombia, etc. So please check our website. And you can become a member of our organization by filling the membership form that we will share also on the comment box. It's free, it's open. So yeah, enjoy. And I'm handing back to you, Laëtitia. But before I do so, actually, before I forget, we are publishing a great op-ed that Laëtitia has led actually in writing. So it's linked to this event on access to COVID vaccines. I'm sure you're going to enjoy it. We're going to share it also in the comment box. Thank you so much. And Laëtitia, it's to you. And yeah, thank you, Neda, for helping us so much.
Yes. Thank you so much, Sarah, and thank you to Bonnie and to Neda and to the entire headquarters team for all of your support, and also preliminary thank yous to our panelists for being willing to be here and having this wonderful conversation with us. With that being said, let's meet our panelists. We have Dr. Melanie Mugur, and she is a clinical physician that is based in Nairobi, Kenya. She serves as the non-communicable diseases focal person for the United Nations Major Group for Children and Youth, and as Africa Director for the Young Professionals Chronic Disease Network, otherwise known as YPCDN. She has 4 years of experience as a general medicine practitioner in Nairobi, and she holds an MBBS, which for those who are not familiar with the term is a medical bachelor's of medicine and surgery from the University of Nairobi. She is a passionate advocate for non-communicable diseases and for mental health. Since the beginning of the COVID-19 pandemic, she has been working on the front lines of the COVID-19 response in Kenya, where she's seen firsthand how the crisis has exposed the vast inequities in accessing quality healthcare across Africa and the impact it has on lives of people living with NCDs. Thank you so much, Dr. Mugur, for being with us. Next, we have Mr. Omari Jones. And Omari is an experienced microbiologist and infectious disease consultant based in Washington, D.C. As a driven scientist, Omari has over 10 years of experience and has played a role in various roles in laboratories supporting the development of novel antibiotics, vaccines, and monoclonal antibodies. Apologies for that goof up, Omari. His research contributions have led to 10 peer-reviewed publications in immunology, pneumonia, and sepsis, and supported the development of 2 novel pathogen-specific therapies that are currently in phase 2 clinical trials. Omari is currently working as an infectious disease consultant and has a strong drive to utilize his knowledge to improve global health. Thank you so much for being with us, Omari.
Thank you.
Next, we have Ms. Rumunzai Ngwani. And Ms. Ngwani is a public health expert specialized in vaccine supply chain and based in Freetown, Sierra Leone. Rumbi, as she will be referred to during our conversation, has 15 years of experience in helping governments across Africa, Sierra Leone, Mozambique, Eswatini, Botswana, and Zimbabwe strengthen their healthcare systems. Her focus areas are vaccine and laboratory diagnostic supply chain systems. Currently, she leads a vaccine data and supply chain project in Sierra Leone. Rumbi holds 2 Masters of Sciences in Biomedical Sciences and Public Health, among other qualifications, and she is currently pursuing a doctorate in public health. And what drives Rumbi is the need to see positive change onto the last mile. While she is not working, she enjoys mentoring young people and students and traveling and cooking. So we're really excited to have her here. Thank you so much for being here with us, Rumbi. And lastly, for myself, my name is Laëtitia. I am a global health consultant, as mentioned, specializing in infectious disease surveillance and outbreak preparedness. In my own experience, I've supported more than a dozen global health security, AMR, and HIV/AIDS projects within Africa and the Middle East, as well as supporting STEM equity for young girls, both in Latin America and the African continent. Since the beginning of COVID, I've actually done work on authoring publications and talks similar to this that are looking at the impact of COVID, both on persons of color as well as the migrant community on the African continent. So thank you. Hopefully that gives you all an idea of who we are, but you did not just come here to listen to who we are. So let's jump into our conversation. Our panel will be 50 minutes and we look forward to having everybody tune in. Please feel free to ask questions and pose questions in the chat box. As mentioned, we will be getting to questions at the second half of the event. We're saving about 30 minutes for that at least. And our first questions are actually going to be targeted towards Rumbi, specifically looking at the vaccine supply chain. So Rumbi, I wonder if you could please provide all of us an understanding of what are the methods that Global South countries, Global South as we're defining it for the sake of this conversation, are using to acquire the COVID-19 vaccine.
Thanks, Laëtitia, and hello everyone again. So most of the countries in the Global South at the beginning of the pandemic and as we were rolling out the COVID-19 vaccine received donations from different countries and manufacturers. We'll look at the COVAX facility, which was in the beginning being spearheaded by WHO, which has donated to many countries so far. And its target has been to target 20% of the population, especially in Africa, and it set aside about 600 million doses to give to the African continent. Obviously, they have been giving to other Global South countries as well, but I'm just going to talk in terms of numbers to the African continent. And so to date, not all the countries have received the 600 million. Some of the vaccines were given in batches, and we are countries, depending on which country it is, the bulk of the countries have received the first batch and are waiting the second batches. And the first batches in most of the countries, in some of the countries have actually run out, looking at Rwanda, Senegal, Ghana, Togo, Tunisia, Eswatini and Botswana, and they're actually anticipating the second batch sometime in May or June, depending on the release from India. And while we look at the donation from the COVAX facility, there's been donations from other countries as well, looking at bilateral agreements between a country and whoever is donating. So we have heard China donating to other countries, we have had India, we've also had the United Arab Emirates also donating to its allies and neighbors. In addition to donations, we have also seen direct purchases, looking into bilateral agreements between countries. There have been countries which have not received donations per se. They've actually went ahead and do direct purchases directly from the manufacturers. Examples would be Malaysia and South Africa, which have done direct purchases for other vaccines. And most of the vaccines that have been donated to date are AstraZeneca, Sinovac, and Sinopharm. But for direct purchases, there's been Johnson & Johnson and Pfizer, as well as the AstraZeneca by countries that have actually purchased. And for the countries which initially received donations, they are actually looking into supplementing, adding on to additional vaccines through direct purchases. Some of the countries have received donation or funding from the World Bank and would ideally be going into direct purchases through the COVAX facility. And so countries, depending on the country, they are at different stages of procuring through the COVAX facility. I would say maybe there's an advantage in terms of pricing if you're buying through the COVAX facility. And also I think for supply chain purposes, it's even easier if you're buying through the COVAX facility, because ideally you'd have to go through Gavi, and the supply chain system would be handled through Gavi, which will be easier for the country. And just looking into some of the things that have been mentioned in terms of supply chain again, we all know we have also had that there are some countries which have had expiries of the AstraZeneca vaccine, and largely because maybe there's been limited uptake from the communities being due to people not really being sure about the effectiveness of the vaccine. And also in some places, it's the number of cases that has been reported, making people believe that it might not be a good thing for them to go ahead and get the vaccine. So looking at the cold chain, as you might know, again, we have been receiving the AstraZeneca in most of the countries which are Global South, and we have been receiving AstraZeneca, Sinovac, Sinopharm, and some few countries receiving Pfizer or Johnson & Johnson. The bulk of the countries have been receiving AstraZeneca and Sinopharm or Sinovac, because the cold chain is ideally matching with routine vaccines which are currently available. And while some of the vaccines like the Pfizer require ultra cold chain, making it very difficult for countries which are not with poor resources to actually be able to have cold chain on the last mile or in the vaccination sites. So again, those are some of the things that we need to look into when we look at what type of vaccine need to be shipped to all these other countries when we look at the cold chain equipment that is available. I think I'll stop here and add on to anything that I might have left out during this discussion. Thank you. Over to you, Laëtitia.
Thank you so much for that, Rimbi. I actually would love to pick a little bit at some of the points that you've just mentioned here, namely that some countries are actually able to procure the vaccines through COVAX through not a donated method, but actually through a more, I imagine, a subsidized purchase method. I think that's an element that for quite a few people that wasn't aware of, that COVAX has a dual functioning arm. I secondly wanted to draw on that point you mentioned, cold chain versus ultra cold chain. I think for some people on this call, in this event who may not know, when you're transmitting anything related to biomedical, whether that is a vaccine, whether that is a specimen, a sample, or even tests, everything is relatively temperature dependent. But when we talk about cold chain, I don't think many of us make that distinction between cold chain and ultra cold chain. I wanted to ask you quickly if you wouldn't mind just explaining the difference between those two.
Yeah, sure, Laëtitia. So when I talk of the ultra cold chain, that's like minus 80 degrees Celsius, very, very low temperatures. And normally we talk of dry ice. So during transportation, vaccines like the Pfizer, they would ideally be transported using dry ice, which is minus 80. And based on the temperature requirements of the Pfizer vaccine, once you need to use it, it needs to be thawed. And normally it is thawed to negative temperature, which is normally minus 25 degrees Celsius. And you can store it, I'm talking about the Pfizer vaccine, you can store under the negative temperatures, which is minus 25, for a period of about 2 weeks. And then you can now immunize. But once it has been thawed, you can't now refreeze it again. It has to be used within the speculated hours that used, which is a limitation if you are talking about countries which do not have capacity to have minus 80 refrigerators, even if especially if you are talking about up to facility level. For most of the people who understand that global south countries, this is something which is not very feasible. Unlike when we're talking about the AstraZeneca, Sinopharm, or Sinovac, the temperature requirement is +2 to +8, which is quite temperatures which are normal refrigerators. And you can have a refrigerator up to facility level or vaccination site at +2 or +8. And also Sinopharm, AstraZeneca, they do not require any freezing. It's just +2, +8, and you can use it depending on the vaccine lifeline. It can be 6 months, it can be 3 months, it can be 7 months, depending on the vaccine that you have received. I don't know if I have answered that clearly, or you still want me to expand on that.
No, I think you've actually done a fantastic job about that. Thank you, Rumbi. I wanted to actually pivot a little bit towards both Omari and Dr. Magor to see if they had anything that they wanted to add in. Dr. Magor, perhaps your perspective in having to receive these vaccines and needing to determine how quickly you can use them, given that, as you mentioned, some of the vaccines, Pfizer and Moderna, require such cold storage that by the time they arrive in the facility, the chances of that the facility has the capacity to replicate that storage, especially if you're thinking of going into health outposts, is fairly limited. And perhaps, Omari, you would also want to touch point on any of that components within the cold chain, from design to the point where it needs to be delivered, why those temperatures are necessary. Melanie, let's start with you and then go to Omari.
All right, thank you, Laëtitia. I think that was a really good presentation from Rumbi. And from my experience, basically here in Kenya and generally within the East Africa region, is we've received the vaccine, specifically AstraZeneca, of which the conditions required for its supply chain are manageable within the East African region, considering what we've been using previously for the other vaccines. So for the other, like Pfizer, the Moderna, we've not received that. And currently, we do not have adequate facilities to support that. Hence, one of the reasons why we do not have it being distributed locally at the moment. Thank you.
Thank you.
Right, absolutely. Melanie brings up a great point, especially how Rumbi has described the ultra cold chain process. It is definitely an expensive system to maintain. And when you're really talking about regions in the global south that really don't have that type of means for ultra cold chain refrigerate or freezing for these vaccines to retain, their integrity for extended period of times, it makes it really difficult to have storage for these vaccines and then implement a dispersion plan for a number of countries in the global south. And that's mostly because these vaccines are built up on mRNA platform, and mRNA itself is it loses its integrity very quickly. Naturally, mRNA is simply meant to be a message within our body. And so once that message is delivered, it degrades fairly rapidly. And so in order to retain the integrity of these vaccines, they need to be retained at very cold temperatures, which, as I mentioned, is difficult for most countries to retain. Even the US had to establish a very unique system in order to retain the integrity of the vaccines when distributing to the public. Over.
Thank you, Amari. And actually, I think that pivots to some of our next questions that this conversation has opened up, which is let's discuss the vaccines that are actually in circulation and in COVID, that are being acquired by COVAX and other means of acquisition. I think Rumbi has set us up in such a point where it might be good to have that background knowledge and understanding of these vaccines. What are there in circulation? Is there a dominance over one over the other? How much of that is fueled by PR and how much of that is actually directed by the science? So Amari, please, over to you.
That's actually a great question. So yeah, Rumbi set it up perfectly, as you definitely hit a good point on not just the initiative of COVAX, but as well as the other bilateral acquisitions that are occurring in a number of different countries. But if we're just talking about donations, particularly associated with COVAX, and just for awareness, for everybody knows, there's about 6 COVID vaccines that have been granted emergency use authorization in various countries throughout the world. However, there are only 2 authorized vaccines that have been delivered to countries in need through the COVAX initiative. And so I just want to backtrack, actually. So the vaccines that have been given emergency use authorization are Pfizer, Moderna, which are both mRNA vaccines, and as we described, have a very expensive systems. Johnson & Johnson, which is on a different type of platform that is a little bit more stable, as well as AstraZeneca's, Gamaleya's, and Sinovac and Sinopharm. But as I stated, despite there being 6 vaccines that have been given authorization, there are only 2 authorized vaccines that are being delivered to countries through COVAX. And these vaccines are AstraZeneca's vaccine and Pfizer's vaccine. More so, there is also a large disparity with the commitment to COVAX between AstraZeneca and Pfizer. COVAX has an agreement for 340 million doses of AstraZeneca's vaccine for 2021 to 2022, but there's only about 1.2 million doses of Pfizer vaccine in the same time period going to be delivered as donations to a number of the global South countries. And so this begs the question, why is there such a large disparity between these agreements, and why are there only 2 vaccines currently represented in the COVAX initiative? And so this disparity we kind of mentioned on and hinted at towards the expensive supply chain that's required to maintain the Pfizer vaccine. But there also are other reasons for these disparities. And the 2 most obvious ones are cost and timing. After this COVID-19 pandemic spanned across the globe, many global North countries began to hedge their resources towards several different companies conducting research and clinical trials for a COVID-19 vaccine. Pfizer and Moderna, the 2 mRNA vaccines actually, were one of the first companies to gain emergency use authorization. And the data that arose from these trials actually far exceeded what many experts believed or predicted would occur, which both vaccines demonstrated an efficacy of about 95%. So early approval, strong efficacy, and limited side effects have since caused a high demand for these 2 vaccines. In addition, both these vaccines require expensive raw materials, specialized ultra cold chains, and just an expensive resource to contain the vaccine integrity in itself. Resources that many global South countries don't have. Conversely, the AstraZeneca vaccine demonstrated slightly lower efficacy preventing mild to moderate COVID-19 infections, but it had equivalent protection from severe COVID-19 infections as the mRNA vaccines. But the cost of the production is far cheaper and far more convenient for shipment and storage because it can be refrigerated at 1 to 8 Celsius temperatures. In addition, AstraZeneca was the first global pharmaceutical company to join COVAX in June 2020 and has strived to support global equitable vaccine access to vaccines. So unlike some of the other currently authorized emergency vaccines, AstraZeneca has committed to a not-for-profit agreement and is selling essentially its vaccines at $3 to $5 per shot. So regarding cost, availability, and sustainability, AstraZeneca's vaccine appears to be the most appropriate for the COVAX initiative. But the bigger reason is, why are we here today? And there's a major problem with the situation. One company should not bear the brunt of the equitable vaccine response to global South countries. The limited pharmaceutical participation in the COVAX initiative is tragic, and it's been mentioned by a number of different political figures. Many authorized for use vaccines are being sold to global North countries with priority and premium. many countries in the global north are also stockpiling COVID-19 vaccines by purchasing extreme quantities of the vaccine at once. And this response most certainly is counterproductive to the donations these countries have made to support the vaccine's access to equality and equity to countries of need. So I just kind of want to go from there that there are several other vaccines that the COVAX initiative intends to include into circulation once and if they're approved for authorization. But I think it really begs the question on, where we are right now, and there's a big gap, and there's a number of things that need to be addressed. And so I'll pass it back over to you, Laëtitia.
Thanks, Amari. And I really want to, if taking a second, I really want to like nail down one of the points that you just mentioned regarding AstraZeneca, Pfizer, and Moderna. Which is the cost of materials. And actually, when we talk about how much like more efficacious or the efficacy of vaccines, what we really mean by that. To your point, when it comes to preventing severe COVID, which respectfully, when a lot of people think of COVID, it's probably severe cases are probably what most people and most countries feared. I mean, AstraZeneca seems to be competing, or at least as good as others. I also wanted to add in like one of the points that you mentioned regarding vaccine stockpile along with just their donation and what's there. I think that's a really important point. And actually the director of WHO, Mr. Tedros, made comment of that many countries who are opting to donate vaccines are actually buying so much of the excess of the supply. And I think that's an important point to take home. There's really a limited amount of these vaccines, whether it's Pfizer, Moderna, AstraZeneca, Sinovac, Sinopharm, the amount of vaccine that is actually being bought up and is far exceeding the abilities for some companies to donate. If, for example, AstraZeneca is able to create in a month 500,000 doses of a vaccine, but they've already got an orders or these pre-orders in from countries for 460,000. That's 40,000 vaccines that they could potentially donate. Even more so, and I think this is some point that you kind of hinted on, and I really wanted to drag it out a little, is that there is something to be said about a country not only having the resources to develop a vaccine, but actually being able to go to an entity and place a pre-order of a vaccine at that certain rate, which a lot of global South countries don't really have that opportunity to do. I mean,
absolutely.
People if you wouldn't mind talking a bit about that.
Yeah, so great points. It's actually interesting. I mean, and just for the audience, I mean, if you really think about it, it's an interesting conundrum, because it's almost saying, a lot of the global North countries are saying we want to help and we understand there's a need for these vaccines. So here's some money. But then when these countries then go to the store to buy said vaccine, there's no supply. So it's one of those situations where the money is useless unless there's a vaccine available. And so it's almost counterproductive. You have these countries that are contributing to the COVAX campaign, but the COVAX campaign can't donate these vaccines if they're not there. If, the production capabilities of the companies they're trying to purchase these vaccines from are already, at their max. And so it is unfortunate. And I think this is something that a lot of political figures and countries really need to understand and really, appreciate what role they're playing into, this current pandemic. But I think there's also a need to really stress the understanding of efficacy and real world effectiveness. And so just to kind of break down those definitions, efficacy essentially is associated with the clinical trial itself. It's essentially asking how well did the vaccine do in the clinical trial. And in these clinical trials, they're controlled. They have certain percentage of, ethnic groups represented. They're implemented at certain sites throughout the world. They have, clinicians that are regularly on call and taking a number of different samples in order to really appreciate the data and the differences between the placebo groups versus the experimental groups that are receiving the vaccine. This isn't a true scenario in the real world scenario. And this also means that, in these vaccine clinical trials, the companies are allowed to distinguish what individuals they don't want in the trial. So for instance, if they have a number of individuals who are on, cancer therapies, maybe they won't be good individuals representing the vaccine efficacy. And, if there's age range limits, maybe babies aren't going to have a strong enough immune response versus, somebody who is an adult. And so all of these things are taken in consideration. However, once the vaccines hit the real world, once they're approved, now you have the real world effectiveness. And this is actually asking, how well does the vaccine do when the environment is no longer controlled? And so I think that's something that really needs to resonate with the audience as well as our political figures when they're messaging, because there is the global public should be very conscious of assumptions that they make about the vaccine's effective capability simply by comparing clinical trial efficacy. And to be honest, this is a tricky subject, as I was describing, but each vaccine clinical trial involves different patients, different clinical trial sizes, different trial locations, different distinctions of infection or prevention, different vaccine concentrations. That alone is a huge variable. All of these trials were conducted at different times. So some of the individuals that were in these trials were challenged with different COVID-19 variables or variants. So all of these factors can change the efficacy results and cannot be directly compared to one another unless those vaccines were directly compared in clinical trial setting. So I think a more valid assessment to make for a lot of these vaccines, especially when political figures are considering, these vaccines themselves, is the ability for these vaccines to prevent mortality. And I think that has been, at least thus far with the authorized vaccine, has been consistent, that majority of them are preventing mortality from upwards from 80 to 90%. But as I said, as we're here today, the biggest problem with the vaccine availability is just the global South needs more.
No, for sure. Absolutely have a couple of other comments I want to bring up, but I also want to open the floor to Rumbi and to Dr. Magor for any components that they'd like to add in.
Yeah, Laëtitia, just coming into when Omari was describing efficacy and effectiveness, and just noting that for AstraZeneca, they are better when the time between the first dose and the second dose is longer. So currently they are saying 8 to 12 weeks. So the longer the time frame between the first dose and the second dose, the more efficacy the vaccine is. So in some countries, they're going at 8 weeks because they're ideally looking at loss to follow up. They don't want to lose clients due to the long time frames. But some countries are actually going beyond the 12 weeks so that they can just improve on the efficacy. Thanks.
Thank you. And just adding on to the point of efficacy, I can talk about it from the public health perspective and what it has actually done in the community level. First of all, right now, with the global level of availability of internet, people are able to see what is shared on social media and various platforms. And because of this, this has affected the response to how people, accept some of these vaccines. There's been a bit of hesitancy based on what has been, published in various outlets. The other key important thing to mention is, while science depicts that between 8 to 12 weeks is the ideal time, there is what is the reality on the ground. At the moment, COVAX is struggling to actually distribute and, export vaccines from India to various countries. So many countries, for example, within the Africa region, are going to give the second doses way beyond the 12 weeks, which is recommended. And that is because that is only the available time that they'll get the vaccines. Thank you.
No, thank you for that, Melanie. I think Dr. Magor, and thank you, Rumbi. I mean, I think you guys hit on some really key points there, which is if you're seeing in practice it's more efficacious after 12 weeks, irrespective of what the clinical trial has shown, you're going to go from greater than 12 weeks. You're going to go for 12 weeks or greater. And likewise, too, many of these scenarios, when we're thinking about recommended, here's the timing for the recommended dosage, here's how we wish to do X, Y, Z. It doesn't take into account that in some circumstances, loss to follow-up is extensive. You do have challenges of the fact that some public health locations are very difficult to reach, in the sense that we think within a global north context, the most difficult thing is going to be having to walk to the location, or perhaps having to bike or take some form of public transit. But in a lot of cases too, it's not even a question of biking or public transit. There's no road. You don't necessarily have, if you're walking and it's dark, it's pitch black, you see nothing, which puts you in danger of, if there is someone on the road, of being potentially harmed. If there are cars on and I use the road very loosely here, you put yourself in danger of being hit or being harmed in some cases. But also too, you both were mentioning very specific countries, and I wanted to pull a bit of a thread on this, because when we are talking about vaccines, I don't think people also realize that vaccines are heavily affected both by the comorbidities within that country, the environment inside that country as well, and the variants that are dominated within that country. When you have a clinical trial that's available and you use perhaps a minimal number of ethnic groups, and I think, Omari, correct me if I'm wrong, but some of the clinical trials within the United States, within at least the Black community, was a very, very small percentage of that. And if you were, for example, to extrapolate that small percentage to any Black person, whether Black American, Black African, Black Caribbean, etc., I mean, those numbers wouldn't hold up for a variety of factors. Maybe we can talk a little bit about that if Omari wants to. What?
That's actually a great point. So the reason why clinical trials are firstly conducted in various regions of the world is it's an attempt to get the best understanding of the efficacy of the vaccine or therapy in various populations. And these are populations in different regions, so they're going to have different diets, different comorbidities, like localized within, their habits in the particular regions. There's a number of intrinsic and extrinsic factors that need to take into account. And especially when you start considering countries that are like in the Sub-Saharan region, there's other pathogens that may contribute negatively to, the host immune response to the vaccine. So these variables are definite factors of vaccine efficacy. And when you start considering population size, as you mentioned, Laëtitia, in a particular clinical trial, so most of the clinical trials for, at least within the US, there was only about 10% representation of African Americans. And so therefore, you only have a small representation on how well that vaccine may do in the real world, because you only had, a small number of individuals represented in those clinical trials.
Thank you for that, Omari. Before we move on to our next question, I definitely wanted to ask this both to Rumi and Dr. Magor. Based off what we're hearing, what do you think are some considerations that need to be taken into account when we're thinking about the efficacy of a vaccine in global South countries? Dr. Magor, may we start with you?
Thank you, Laëtitia. I think one of the key important issues to look into and taking into efficacy is, first of all, getting involved a bit more actively and using a bit more of our population during the initial clinical trials. Because, within the scientific world, then they'll be able to take into consideration all the other confounding factors that are required. Yeah. Over to you.
Thank you, Rumi.
Yeah, I would agree with Dr. Melanie as well. I think, like what Omari said, a smaller population of the Afro-American has been involved in this clinical trials. So we wouldn't ideally know of the efficacy when it comes to this population. So inclusion of that population in future clinical would be very helpful for us to know where we really stand.
Absolutely. And a lot of the part of that information and why it's beneficial to even long-term into vaccines is it allows us to be armed with the information so that when vaccines are on the ground, we can answer certain questions and we can begin to debunk any sort of myths or rumors and honestly be able to answer legitimate questions with more than we've seen it work so far. We haven't seen enough issues come up that would make us have cause for concern. And actually on that point, I would like to ask you, Dr. Magor, so now I think we've discussed now the vaccine acquisition of the vaccine, the supply chain itself. We discussed the vaccines in circulations and getting a little bit into the meat of what are some of the compounding factors within the vaccine to take into consideration. But now I think we should be getting to that place of vaccine access and acceptability. So I'd like to ask you, Dr. Magor, how has the COVID vaccine access and acceptability been once the vaccine, whichever vaccine it is available in global South countries, particularly in scenarios where perhaps more than one vaccine is available?
Thank you, Laëtitia, and that's a very, very important question. And maybe just to lay a background of what's going on. Remember, this COVID vaccine has come at a very timely manner when this pandemic is, raging. Many countries are battling the third wave right now. Unfortunately, many countries previously, their immunization programs have focused on vaccinating children and not when there's a pandemic. So the population is usually a little bit controlled. However, during this time, we're not only we're vaccinating adults, and we're planning to do mass vaccinations. Also, there's a very short window period available between the vaccine availability up to the time that they need to utilize during to these populations. These are very critical issues to look into. And when addressing this question, I look into two areas. First of all, the issues that are affecting the nationals or the countries, and then the issues that are affecting the individuals. For example, within the individual countries, key amongst them is the political commitment, leadership, and governance. You find that in countries whereby the strong leadership and acceptability of these vaccines were some of the initial countries to actually accept and sign up for the COVAX facility. Furthermore, some of these countries actually invested and even set aside, extra funds to purchase these, vaccines and anything that was required to, deliver. So that is a very key important thing in ensuring availability. The other thing in terms of access is the regulation. COVAX would bring the vaccine to the country, but the regulatory bodies within the country says no, this does not meet the requirement or the criteria that we need to use these drugs within the country. So some of those legal regulations need to be done away with, or actually they can work in collaboration with some of the UN agencies. For example, I know many global South countries actually use the WHO regulatory body, especially when you have such emergency use drugs. Next is the supply chain within the country. Once we have the vaccines, just distributing it, simple things as the road network, simple things as the communication network, they may sound very trivial, but these play a very important role in ensuring the vaccine access to the population, for example, in the rural areas or in the very hard to reach areas. Next, we discuss equity. One of, what the reason why we actually have this webinar today. Equity is something that can be accessed in or discussed in various angles. And in between the countries, we look at specific things. How are people able to access this vaccination? We've seen several countries, develop criteria. For example, one that has been uniform across all countries is healthcare workers top the list. That one is undebatable. However, when you go down and you rediscuss further, who is a healthcare worker? Several people have actually not been able to know that this is not just a doctor or a nurse. It also involves the cleaner, the catering personnel, the security within the hospitals or anywhere within the healthcare facilities. So communication about such important things. Issues about transparency and corruption. There's no transparency on the data who has actually been vaccinated. Where can they get this vaccination? Which centers are they? And these are key important things which affect even the trust and the acceptability of this vaccination within the countries. And what countries have also been struggling is how do they define the at-risk population? For example, comorbidities. Issues like obesity may be a real comorbidity in Europe or in the US, but it's not a very strong comorbidity within the Africa region. However, things like diabetes, hypertension, HIV/AIDS, these are important things. So how do they ensure they're able to stratify and classify the population, looking at the at-risk properly and ensuring that they actually follow the ethical requirements where they're not doing any harm, they're ensuring adequate, use of the vaccines, and they are ensuring equity amongst, the population. The next important thing to look at is data. And data, we can look at it in two ways. Data in terms of the available vaccine, but even data, breaking it further down. For example, when you talk about healthcare workers, where do you start? The urban city? Do you go to the rural areas? Do you go to where over the last 3 weeks you've had the highest number of the, COVID infections? When you further go down and look at the comorbidities, where do you start from? For example, I'll talk about non-communicable diseases because it's a passion or an area of interest to me. When you talk about people with non-communicable diseases, do you put those with hypertension first or diabetes and even those numbers are not available in many of these global south countries. So it even becomes difficult for governments and countries to plan ahead, to have a targeted number of vaccines for them to actually acquire. Next is to discuss things about human resource. This is an over-discussed issue. We're already struggling even before the COVID. So we have the COVID here. We're struggling to expand the human resource, to utilize it within the hospitals. And then there we have the vaccines. We want to further stretch the human resource to deliver these vaccines within a very short time. So this is a very key issue. And that is what has actually affected so many populations and many countries. Finally, let's talk about coordination. It is very difficult for any country or for any region to say they're going to do this alone, for any government to think they'll be able to do this alone. There is need to partner with private sector. There has been need to work very closely with civil society, faith-based organizations, because things as simple as communication, things to demystify the myths relating to these vaccines. For example, there's been a very common myth going around about the vaccine making people not be able to, get babies and all. People who are very important in helping such, demystify things and also discuss are these partners. Furthermore, we've had civil society organizations and non-governmental organizations who are running healthcare programs. So they can actually be able to help deliver some of these vaccines, if not create the pathways or the opportunities to deliver the vaccines. And then if we look at, let's now go to the individual. And this is where we talk about two things. There has been vaccine urgency or the urge to get the vaccine. And this, if you look at the stratified population, so this would be the young people around my age and, early 30s, early 40s and all that. These are people who are, very anxious because of the information that they've gotten all over, the media and even the social media. However, they're anxious to get the vaccine. But when you look at what the government has put as stratified or at-risk population, they do not have these comorbidities. They're very young. They're not healthcare workers. So what do we do? So that becomes really a big problem. They're anxious, they want the vaccine, but it's not there. Then there's the other population where we have vaccine hesitancy. This has occurred because of the myth that has been peddled around. This has occurred because some of actually the true information, for example, the adverse effects, the side effects that have been documented, all of this which are still under investigation and have not been fully, documented as the final effects. So this can cause a bit of vaccine hesitancy. Finally, we have the elder population who they are old, they are at risk of so many things. They have almost 10 of those comorbidities. If you list, they'll fall under any of the at-risk populations. So they wonder, if I get this vaccine, is it going to make it worse for me? So this is what, different governments are actually struggling and different populations are struggling to look at. How do we balance between the two? And this brings me to, a very important and critical point. As we keep discussing about, this access to vaccine and equity and equality, it even makes you wonder, is it really a justified discussion to think about it when these vaccines are not there at all? We cannot even talk about things like infrastructure and whatnot, when ideally we do not even have the vaccines. So I think those are some of the key areas to look at when you think about the nationals and when you think about the individuals. Thank you. Over to you, Laëtitia.
Thank you so much, Dr. McGraw. That was wonderful. And I really wanted to point out one element that I don't think many people think about, which is the at-risk group. That definition of who is the at-risk population is even in a location like the US, for example, that changes wildly depending on to whom you're speaking and what do you define as a significant comorbidity that constitutes being at risk. For example, in California, United States, in Northern California, when they actually looked at the at-risk population, they specifically pointed to, okay, you got your 65 and 75 and older, make sure they get their vaccines, please. But when they changed that view to, let's say, the Latinx population, the age bracket moved. There actually was this thing, they saw more cases, more severe cases and death at a much younger age bracket. And so when it came down to getting the vaccine, they said, but wait a second, how are we last, or how are we behind this group when, at least within our community, we are actually the most at risk, not only the most at risk, but the most people getting the severe cases of COVID-19. I also wanted to talk to you, specifically, you brought up a topic about road networks, which I think when we are talking about vaccines, we think about, but we don't actually focus on, which is in some countries when vaccines are distributed, it is not that you have the vaccines are necessarily brought straight to you. Sometimes it's everything is at a warehouse, it goes from one location and then eventually to you. And based off what both Rumbi and Omari have mentioned, if you consider vaccines that are very temperature sensitive and at high risk of the mRNA denaturing, as well as facilities being able to receive those sort of temperature sensitive vaccines, I mean, I imagine that would imply that once you get these vaccines, you either have to have a line of people ready to use them, or really risk that whatever supply you're getting in is probably not getting used, but it's being counted against you as, we've given you 5,000 vaccines. Granted, you only have 500 people in line, and these vaccines are supposed to be stored at -80, and you only have a -20 fridge, but we gave you 5,000 vaccines. So you shouldn't be needing any more if your catchment population is 5,200, let's say. Would you mind speaking a little bit on that?
Yes. So actually what I've given an example is in some of, a bit more resource limited. Let me give a very good example of two countries. We have Rwanda and we have Ghana. Rwanda were able to actually utilize a lot of their vaccines over about a month. They were actually done with most of their vaccines. And if you look at how they were able to do this, is through effective coordination. So despite there being a difficult, infrastructure or road network, they've been able to innovate. For example, they have drones that actually deliver some of these vaccines. They did mock exercises of the vaccination before the vaccine actually arrived in their countries. And some of them, for example, Ghana, Angola, actually did pre-registration and pre-booking for the vaccine. So they're able to plan ahead of time. So we look at where there's no infrastructure, how are these governments or populations, how are they being innovative to use, the limited resources that they have within this short time? As you remember, I mentioned, there's a very short window period between the time the vaccine arrives and the time you actually have to utilize. So if you're not well coordinated, whether the infrastructure is good or not, then you're still going to lose and have a lot of wastages of these vaccines. Thank you.
Thank you. Just tying on this question before opening up to the group would be to Rumbi, specifically speaking on that coordination component. We're looking what Dr. McGraw is discussing. How do you feel the public and the private sector of vaccine supply chain are coordinating with the actual vaccine deliverers, for lack of a better term? Do you feel that that coordination is existing, and how has that been playing out for COVID?
Personally, I think the coordination has not been that structured, given the small window period that we've been given to roll out and to plan. And I think also touching on what Dr. Melanie mentioned, that we need to plan ahead, like what other countries like Ghana have and Rwanda have done. I think that coordination is still much needed. I'll talk of when we're speaking of the low uptake of the vaccine. In some parts of the African continent, like the West Africa, the uptake has been low in some of the countries. Reason being, one, the number of cases have remained low. The number of deaths have also remained low. So if you come in and say to somebody they should take the vaccine, they don't really see the need. But then if there were private sector social mobilization organizations which can go into the communities and try and encourage people to take, and also coming in and looping in traditional healers, faith-based leaders, influential in societies and communities that people would ideally listen to, that would go a long way. But again, that has not been done properly. And I'm hoping that as we progress with vaccination, that could be something that can be improved in the bulk of the countries, because uptake remains low in most of the countries. And as we speak now, we are likely to go into another set of expiries. While we see a lot of consumption of the vaccine in other parts of the African continent and the global south, there are some countries which are actually underutilizing the vaccine and it's going into expiry. And also looking into coordination, like what Dr. Melanie mentioned, if we could coordinate as countries, if we know our uptake is low, why would we not give the vaccine to a country which is now stocked out? I spoke of Rwanda, it's already stocked out of the AstraZeneca, but there are countries which are actually at risk of getting expiries. Why not give Rwanda so that Rwanda can utilize, because the uptake is quite high. So that coordination again is really needed. And I think if the private sector is going to come in, it could ideally alleviate the burden from the government and come in and assist with that coordination and make it practical or feasible. Yeah, over to you, Laëtitia.
Thank you, Rumi. Actually, thank you to all of our speakers for this lively discussion and engagement. I'd like to open the floor to our audience members. If anyone has any questions, I'll ask that you feel free to either unmute yourself and ask your question, or you can put it in the chat. So anyone here would like to ask any questions? So
I don't have a question, but I just wanted to share that I am learning so much here and I'm very appreciative of it. And I just wanted to have a little bit more of more feedback on the issue related to what you mentioned earlier, Melanie and Rumbi, on how to communicate more efficiently with the population, with the communities, and how to engage more with CSOs, civil society organizations, local leaders, religious leaders, etc. If you had any recommendations based on previous strategies that you have seen working, or anything else.
So maybe I can give two examples. Previously, what I've seen happening when we have mass vaccination, especially for children, for example, during the polio or when we have the measles vaccination being rolled out, we find that this is publicized usually at least a week or two. There are usually flyers, being given in the communities. There's a lot of presentation within, televised media, print media, and what is more important is actually radio. Radio has a huge base of reach out. It has more population, and it actually has a lot of acceptability within the communities, because they see this as, like people with authority and a lot of legitimacy. So those are some of the things that need to be utilized. And of course, it will have to be contextual between countries. For example, I know in my country, yes, radio will work really well. I also know within many other East African countries, besides that, we have community healthcare workers and community health extension workers who've previously been utilized, because these are members of the community. They can be able to sit down within the groups and actually share the information. We have key informant groups, for example, women groups. In some cases, they've actually even utilized some political groups within, the communities. We have administrators within different communities. The small local, administrators can actually work as influencers. And even more important is the learning institutions. Previously, they've actually worked really well in helping to disseminate information. When you talk about the civil society organizations and the non-governmental organizations, several of them work in healthcare space, and that is very easy to work with them. However, look into those who do work in the non-healthcare space. For example, those who work in the communication, in security, they actually reach out to far outreach places, the rural areas, the far to reach areas. And this is what we need right now during the COVID vaccination campaigns and even the COVID prevention campaigns. So we need to look further beyond, the healthcare sector. Furthermore, we can also look at, multisectoral and intersectoral approach. This is not a healthcare problem. This is everyone's problem. So government should also look at how can they work with other ministries within their, their institutions. For example, the Ministry of Education has a really wide network. When they're distributing, resources to schools, there's a way they go to these schools. The ministry that, deals with defense and all, if, for example, we're stretched out with human resource, you can easily actually commandeer and use the resources, the human resource available within the security sector to support some of this. So it's really being innovative and seeing where can you collaborate and coordinate and partner, and where can you work together. Thank you.
Yeah, thank you for that. Thank you for that, Dr. Magor, and thank you for your question, Sarah. We have a question that was asked here in the chat, and I think this question is targeted to all three persons, but Amari, this may speak more to you. This question was regarding the vaccination patent. So for those just to offer some back information for others, all of the different vaccines that are currently out, of course, because they are within a particular country, that company owns that patent. And one question that's being asked is, why does there seem to be a reluctancy in sharing the vaccine patent to allow for production to happen in other countries? Particularly, and this example is targeted towards the Middle East, but in some area, in one particular country, no, it is really unclear to others whether there is vaccine access, and it is really hard also to trust pharmacists who claim that they have it when they are administering the vaccine, since you have very few methods by which to verify that. What is the politicalization or the rationale behind not sharing the patent? Wouldn't it put more countries in a place of strength and leadership on the global stage to lead that movement? And before just opening the floor, I would like to mention that first of all, that is an absolutely wonderful question. And it is an interesting question too, because in terms of taking a stance on the global stage, we do have to remember as well that there are countries like China and India who are producing vaccines, not only their own vaccines, but also are supporting the production of vaccines that we're commonly used to seeing. AstraZeneca, for example, is also produced in India in the Serum Institute. But actually, in some circumstances, their resources, given what's currently happening in India and their need to vaccinate, are such that countries have to modulate how much they can actually produce for others as they try to deal within their own internal population. But Amari, not to steal your thunder, please take it away.
No, I think that's a great question, and props to the person that asked that question. It's something that is, many people are asking, and I think most people know the answer to this question is these pharmaceutical companies, although, they, for the most part, have produced these vaccines in a rapid period of time, and they are probably selling them at lower cost than what they would normally sell any new vaccine for a pandemic of this nature. But stopping right there, if you look at the stocks of Moderna, for instance, the company stocks have skyrocketed. The leadership of that company has made a lot of money in the sale of these vaccines. Now, I think to some degree, it's a little bit unfair to target Moderna because it is a smaller company, so they can't produce enough vaccine themselves with their own facilities. But it brings up then the next question, well, if you can't do it, should you allow others to do it for you? Should you release that licensure so other entities can actually produce the vaccine and may be a preferred vaccine in some parts of the world versus others? And I think that begs the question, both also just, with the AstraZeneca situation right now with India, the Serum Institute right now is trying to, appease their own situation right now. And so therefore they are incapable of making the deliveries that COVAX, plan for them to deliver to the global south. But I think on the other end is if, a company like AstraZeneca in the same sense released their licensure to other entities in the global south, that'll allow for further production and allow us to potentially get out of this pandemic at a more, effective rate. So.
Thanks for that, Amari. And I also would like to add too that when it comes to these patents, like you're right, absolutely being able to have access to these patents and being able to share that load of production is necessary. But I also do want to mention that there's a huge resource question here. There are some locations that are honestly just able to manufacture a significant number of vaccines compared to other locations. And for some countries too, as you'll notice within the global south, and it's actually happened quite often historically, you'll see people trying to manufacture and produce things so that they can sell both outwards, so they can have the funds to be able to support their inner workings. By that, I mean, if you're in a country in which they're saying, we can produce the vaccine and that's great. And as much as we need the vaccine, we still have a high propensity of cases. So we would actually love to use that money instead to buy oxygen tanks or to be able to support our systems. You'll see it's quite often that people have to make that uncomfortable trade-off. Mm-hmm. Do we lower our vaccination load in recognizing that we're going to be able to use that money to deal with the most critical cases, but we're not actually going to have suppression at the same rate that we personally would like? Rumbi, Dr. Magor, any comments that you'd like to add towards this?
I think what is important for everybody to just understand, this is a pandemic. The world is in a humanitarian crisis at the moment. The sooner we get out of this thing, the better for everybody. Whether it is business-wise, whether it is politics, whether, generally livelihood, the sooner we get out of this, the better. So maybe what I would ask of pharmaceutical companies, corporations, their stakeholders, and, everybody is, why don't we have temporary, for example, they can temporary waiver the rights of this intellectual property that relates specifically to some aspects of the COVID, vaccines and some of the products and technologies that they're producing. It can be a year, it can be two, whatever is feasibly acceptable within, their discussion. And this would enable countries that are actually able to invest to produce some of these products or technologies, or completely the whole of the vaccine. For example, I know the African Union through the CBC has been engaging and starting to have discussions and seeing which countries are able to invest, who is able to do what and all that. If, for example, my country says, yes, we're able to invest and we actually get the resources, it's going to be difficult if we do not have the intellectual property. So we're actually asking for temporary waiver. Once we're able and we're in a stable condition, then the waiver can be closed up, and I'm sure the pharmaceutical companies then can be able to recoup their profits. But what we need to look at right now is, let's have a people-centered approach. Let's look at ways that we can build forward better. And by doing that, we have to consider everybody to ensure there's equity and equality. Thank you.
Thank you for that. Thank you for that, Dr. Magor. Rumbi?
Just to add to that, I understand what you're saying, Dr. Melanie, but I don't think pharmaceutical companies do think about that, because this is for them to thrive and for very strong bodies to come up and try to advocate for the waivers. But otherwise, I think as long as pharmaceutical companies, some of them are actually getting visibility and coming up and for them to really slow down or accept any other form of them not really making profit, I don't think it will be something that is easy. But again, I think we need bodies which are very strong, like you spoke of the CDC. If they are coming in and trying to advocate for waivers, then we might have a chance. But the way they think is very different from the public health perspective that you're talking about.
Definitely.
I think that's a great point that Rumbi brought up is, I mean, as I mentioned, Moderna, their stock skyrocketed. This is their first approved vaccine in market. And so, as Rumbi mentioned, this is their lifeline right now. So if they release their technology into the public, even just as a waiver, I'm sure their investors are no longer excited about, the capabilities of their company. And so it can actually have detrimental effects on their company. And most of these IPs are not just the vaccine, but more so the technology itself. So these mRNA technologies, as mentioned in one of the comments, this is where the patent really relies, is how they've developed the mRNA technology to put it in form of these vaccines for human use. And these companies intend to use these same technologies for other medications as well. And so it is a hard ask, but I do think that it is something that needs pressure. There needs to be some compromise, given that we are in a pandemic, and more so, these vaccines are only acute if only portions of the world are vaccinated, immunized. So even if the U.S. hits its immunization mark of having herd immunity, if most of the global south does not have that, there's going to be another variant that emerges and then allows for escape infections. And these are scenarios that we're seeing in South Africa, Brazil, and possibly India. Right now, the data is too early to say, but there are variants that are emerging every day. And so the longer certain populations are not vaccinated, the more we are all susceptible to this pandemic, being persistent. And so it is definitely a scenario where it really needs some serious questions to be asked. And I know that at least the US right now is getting to a point where there's lower demand versus supply. And so the US is considering options of, now donating a lot of these vaccines to other countries. And I'm hoping those countries are global South countries, not our partners in the global North, even though there's going to be requests there, Europe being an example of wanting more vaccine, because, as I said, it's a global issue.
Yeah, no, I think you brought up a really excellent point there, Mari. I mean, honestly, too, a lot of the question just comes back down to technology. And I think this is consistent across everybody, that usually the same technology that is for one vaccine is being pushed through many others. And it is an expensive thing to give out. I mean, it's complicated for someone to say, let's take a shot at that and let's try to do that. At the same time, though, if we're going to go by that definition, then there does need to be some sort of mental cap on what vaccines people are buying, and also the reason for why things are shifting in the way that they're shifting. I think that you brought up a really good point. Like, before AstraZeneca's started getting some questionable PR in real life scenarios, they had already agreed to donate a significant amount of vaccines through COVAX and to make sure that there was vaccine equity. And because of some of the information that is now coming out, particularly within global North countries, you'll see a lot more people saying, oh, well, I don't want AstraZeneca because I think it's inferior. So let's send that downwards. And that's actually causing a lot of issues when it eventually does hit other countries, because you hear that, oh, am I getting the vaccine that you don't want? Am I getting the vaccine that can most likely cause me harm? Basically, if I'm from a global South country, am I getting shortchanged from a particular vaccine? And a lot of that communication actually isn't correct because of some of the points you mentioned. Variants, I mean, there's a British variant. There is Brazilian variant, yes. And even the strain of COVID-19 that was dominant in the United States, it's actually more closely aligned to what was circulating in Europe. So these are very much situations that do happen. And really one of the dangers in vaccine inequity is that if you have a vaccine, if you get a vaccine that, for example, prevents you from getting severe COVID, but maybe can get you like very, very mild COVID, at this point, it's very likely that mild COVID can still transmit. And if you're moving to global South populations, you are now just encouraging that virus to move forward and forward. But I did want to address a question, and I apologize for getting anybody else who's going to speak, because one person here had a question was, how do we manage the fear of individuals not accepting vaccinations coming from the global north because of the fear of the possibility of receiving less effective versions of the vaccines, as has been common with other healthcare practices recorded in history towards racial minorities? And actually, I think that would be a really great question for both Melanie and Omari to speak to, because yes, Grace, if you don't mind my using your name in this context, you are correct. There's historically many reasons for people not wanting to trust what's coming downwards, especially if there are bad reps around it. Also, too, a lot of the data and information surrounding some of this stuff is greatly misleading in terms of how it's being communicated outwards within the global north, and then how that information is feeding through. So perhaps, Amara, you might want to talk to about some of the misconceptions that come with that communication. And Melanie, perhaps you can talk to some efforts that have been made to try to address or deal with those fears. Omari, after you.
So we live in an interesting time now where, I can literally go to LinkedIn, Twitter, and state something that, let's say, I literally just saw in the lab, post it, and within 24 hours, a number of scientists and other public health officials can see that. And we actually see that with, we've actually saw that throughout this pandemic. Twitter became the new pre-print platform where you had a finding, and rather than waiting to have it published and vetted by, other peer, your peers, you could put it on Twitter, and now it's out in the world. And I say that where it's been a perk as far as really understanding, certain characteristics of the pandemic as it was emerging, but it also has been, has a negative impact, because misinformation can occur through this path. And once it's out in the world, it's there, so anybody can search it, and it's just then present. So it is a difficult question. And I really think that, we really need both the global north as a whole, our experts, as well as other countries in the global south, really supporting refined and peer-reviewed reference data and disseminating out into their public. Because when you have, the circulation of misinformation, it leads to certain aspects and certain perspectives of one vaccine being less effective than the other. And as I mentioned before, efficacy is not the same as real-world effectiveness. And so just because one vaccine appeared to have a good efficacy in clinical trials, for instance, let me just reference Moderna, those trials came out early in the pandemic. Whereas if you look at Johnson & Johnson, for example, Johnson & Johnson was one of the first vaccines that was seen to be clinically relevant against the South African variant. And although the efficacy was lower than the observed efficacy of Moderna or Pfizer's, those vaccines weren't tested against those variants. And so we have no idea what the true real-world efficacy of those vaccines are against those variants in a large population. And so those are the things that the politicians and leaders need to really express, that what is going to be beneficial for your public? How do you convey that? And who else do you need to support that, whether it be the pharmaceuticals or, your neighboring countries and or partners? And I'll pass it on.
Dr. McGoy?
Thank you. Maybe I'll just add to what Omari has already, discussed. And to this, I'll look into three things: communication, coordination, and regulation. So basically, coordination would be, yes, if you're gonna get, donations of maybe the extra vaccines or some which were already pre-ordered, but then it's redirected to the global south. There should be proper coordination, amongst the institutions doing this, exchanges, collaboration between, these countries, such that they ensure the proper mechanisms are followed. And this comes into, it will be an overlap with the regulation and communication as well. When I talk about regulation, first will be the technical aspect. And with this, we're looking at the technical scientific regulation as well as legal regulations. Basically, what is required, if it's the supply chain system, is it looking at, the shelf life of these vaccines? So those need to be in place amongst these two institutions that are exchanging the vaccines. And then when you look at communication, besides the technical communication that will be going on, there needs to be communication to the communities and to the ground level. And this also will involve a lot of coordination. This is where you now bring in, your local CSOs, your media, basically who will help you pass down the information to the ground. By doing all these three things, you're ensuring there's legitimacy, you're ensuring there's trust across the process, because you can prove you actually followed through this process. And when you communicate to the people on the ground, even when this medication is delivered, then it will be acceptable. Also, when looking at regulation, these vaccines, they do not only need to be tested at the point of exit. I'm sure there are technical, regulations and guidelines that guide how they need to be tested for efficacy, and all those things that need to be checked to ensure they're actually good for consumption by the population. And by doing all this, being transparent and publishing what is acceptable to be published to the media and to the the general population, this will actually increase trust to the population and ensure we do not waste a lot more of the vaccines. Yeah.
Thank you so much, Dr. Magor. We do have one last question that was asked from a member of the audience, so we will be finishing a few minutes delayed if people don't mind bearing with us. I think this is actually a very good question, considering the breadth of knowledge that's on this panel. And it's actually touching on one aspect we've talked about now. So to offer some background to individuals, because of what's been happening in India, the Serum Institute, which was one of the major producers of the AstraZeneca vaccine for COVAX, has actually, but either through their own volition or with support from the government, has actually reduced their ability to be able to contribute to the overall initiative. And the question that is being asked as a result of this is, since there is now a reduction and some countries are at risk of running out of vaccine due to high uptake, what do we do when people are faced with the question of mixing vaccines or considering the safety of that, particularly on vaccines that from a surface level perspective appear to use the same mechanism of immune delivery? And I guess let's maybe talk about it from two perspectives. Omari, perhaps you can talk about it from a more microbiological and immunological perspective. And then Dr. Magor, perhaps you can talk to us about how those, if you've come across those situations, and how do we deal with that on at a clinical individual level. And perhaps Rumbi, you can speak to that from a supply chain perspective if you would like. Omari?
Yeah, so that is a very interesting question and an obvious dilemma. Yeah, there is situations where, as you mentioned, AstraZeneca vaccine may not be available for somebody's second shot per se. And so therefore, then what do you do in order to keep them on the regimen to gain their immunity against COVID-19? And this is something that at least the EMA has juggled with quite a bit. I know that there is some countries within Europe that have suggested AstraZeneca and then Pfizer or vice versa as options. But the options that are being played out in a number of different countries as considerations, one thing that really needs to be noted is these are not recommendations coming from the pharmaceutical companies themselves. And I say this more so as a researcher when I have conducted studies and you change vaccination regimes or you change the products of those vaccination regimes, it can change the outcome of the results. And so now a number of experts are considering these options, and they're still weighing these options as being more beneficial than detrimental. But as I'm stating it, these are scenarios that are being considered by country. And so they're not something that these aren't scenarios that are being recommended as a whole. And so it really definitely requires the country leaders to dig into the data and ultimately make that suggestion. But there isn't really any data out there that we can reference in clinical trials saying, Pfizer then AstraZeneca has this efficacy or vice versa. So this is really kind of a gray area. And I will push that back over to the rest of the panel.
Dr. Magor?
All right, this is quite an interesting question that has actually something I've been following closely over the last 1 week because it's a real question that we are actually facing in my country. And it's almost a question I'd be shy to give an authoritative answer because as Omari has said, we do not have any documented evidence. We do not have any, proof that this can actually work. Yes, there's the science that is known. A lot is speculation. There's this, time period that is expected between, one vaccine to the other, except for Johnson & Johnson, where people are able to get only one vaccine. There's also still the question of what if just one dose could be adequate if we vaccinate enough people. So it's really, it's a technical question to look into. There's still a lot of discussion, a lot of debate, a lot of, a lot of information being shared out there. And I genuinely will not give a one authoritative answer on this. I would say the jury is still out. It's still a watch and wait situation until we know. Maybe over the next 2 months, we might be able to actually get, some comparative answers to talk about this. Yeah.
Wonderful. Rumbi, did you have anything you'd like to add on this topic?
I will just go back to the earlier discussions. We have different manufacturers using different technologies, and all of them are working in silo. So for us to really say you can jump from one vaccine to the next will be very difficult to say at this point in time. And again, remember, no particular vaccine is like very pre-qualified at this stage. We're still learning, we're still discovering different outcomes of each vaccine. So really to switch from one vaccine and get to another one, the outcomes might be completely different. And we don't even know whether if I come today and tomorrow I'm getting Johnson & Johnson, what could be the impact on my health? So again, like what Dr. Melanie said, it's very difficult to really say that is possible. We can only wait and see depending on what is coming out. But I would say for countries which still have the vaccine, this is the time for them to plan ahead. If they still have some AstraZeneca, then they should be planning on the second dose and limit the number of people that they're giving the first dose so that they could be able to accommodate the second dose to the population. And because we don't know how long India is going to go through the phase that it's going through. So if we have something, then we better plan for the second dose for our population.
Thank you so much.
Over to you.
Thank you so much, Rumbi. And I guess I would just end by pointing out that a lot of this information and most of these questions that people have are completely valid, given the shortage of vaccine, the accessibility, or in many cases, the lack thereof of the vaccine. But I also want to remind a lot of individuals that we are in a unique situation that many people have not experienced, save if you've lived through perhaps the Ebola outbreak in any respective country. These vaccines are being rolled out and figured out in real time. So some of these questions that we're asking, intermixing, is Sputnik perhaps better than AstraZeneca because of shortages? A lot of the answers for that, as unsatisfying as they are, I don't know yet, because we are trying to figure this out, and we have the clinical data, sure, but the clinical data was not designed and captured the breadth of variability in a lot of these real world scenarios. And so everything that we're stating now is based off fact, off of experience and what we know. But in all of this, we also recognize that this information can change and should be changing as more data becomes available, and as we better understand these dynamics. I understand that we have gone a little bit over, but I very much want to thank every one of our participants for your time here. And I absolutely want to thank our panelists for their time and their expertise, for sharing your knowledge and your insights and engaging so much with us. I've had a really great time, and I hope that you all have had a great time as well. Please, for those, just as a reminder, this event is recorded and will be up on YouTube. You can find it linked through WCAPS social media, through Twitter, WCAPS.net, and through our LinkedIn and our website. Thank you all so much, and have a wonderful afternoon, evening, and I don't think anyone's going from the morning unless you're calling from Australia. And if you have any more questions, information about this, please reach out to wcaps.org and sign up and join our network once you're there. Thank you, everyone. Please take care.
Thank you.
Thank you, everyone. Goodbye.
Thank you.
Bye.